Dr. Mohamed, thank you for joining us. You talked about hepatitis B in pregnant women, and if I got the gist of your talk correctly, it is about making sure that the infant is not transmitted hepatitis B. Can you cover the big picture of your topic?
Sure. So the main focus is actually ensuring that mothers who are surface antigen positive, that means who has hepatitis B, do not transmit to the babies. Because the risk of having the infection at birth means there's a high chance of having chronic infection or lifelong infection. So what we need to break the cycle is actually first there must be an emphasis on the birth dose vaccination, which is given within 12 hours of delivery, plus the first dose of the hepatitis B vaccination, and complete it within the 6 months, the 3 doses within 6 months. So that itself can help prevent the mother-to-child transmission of hepatitis B up to 95%. However, there are some studies to show that if the mothers have got very high virus level or viremia, then the chance of transmitting is much higher. So you want to prevent that transmission to occur. So there's an additional prevention that's needed, which is actually giving mothers with high virus count or viral load antiviral therapy during the pregnancy itself. So that has been shown to reduce further the transmission rate, and it can be as low as 0 if you actually manage to catch the mother and treat early enough during the pregnancy, and usually given in the 3rd trimester of the pregnancy.
Yes, I noticed there was specific timing for that.
Yes.
So not in the first 2 trimesters?
No, because classically people avoid having drugs given in the first trimester, mainly because that's the time of development of the fetus, and that is actually, if it's given just for the sake of preventing mother-to-child transmission, the drug takes about 3 months to work in general, unless there is actually this risk being higher when the mother's viral load is very high. So you may want to start as early as 24 weeks of the pregnancy instead of the 30 to 32 weeks. So basically here we are talking about reduction of the virus at the time of delivery, because that's when the infection occur or gets transmitted to the baby around the perinatal period at the time of delivery.
And also stopping the antiviral
Yes.
weeks before delivery was also important.
It's actually stopping at delivery itself. The minimum is at delivery itself. Some continue further up to 4 to 12 weeks after delivery because of the fear of getting a flare of hepatitis. Because it's well known when you stop the antiviral treatment, and it's not just with therapy, with pregnancy itself, the virus tend to have a little chance of flaring up post-delivery. And that's related to some hormonal changes that occur during the delivery period, and this risk can be as high as 25%. And in general, the fortunate thing is that the flare that occur is actually quite mild in most circumstances, unless the mother did have advanced liver disease or cirrhosis, which was not detected. And so by right, this should be picked up earlier, and the treatment should be continued rather than stopped after delivery.
Is there the risk of creating drug-resistant viruses by giving antivirals, as you would see in an antibiotic?
I think the risk of actually having it transmitted to the risk of having the drug itself in the baby is actually quite low, so that's why even breastfeeding is not contraindicated if the mothers are actually taking antiviral therapy. So in general, we say it's quite safe, and that's why we only allow certain category drugs to be given during pregnancy. We are looking at the risk, balancing risk and benefit. So most times that we actually have now, we actually use category B pregnancy drugs because of the fact that there are no animal studies that suggest that it's harmful.
What are the factors besides high viral load associated with increased risk of prenatal transmission of HBV in pregnant women with hepatitis B?
Most studies have shown that the viral load or the maternal viral load is the most important factor. But I think it has been stressed that the most important preventive strategy is still the vaccination itself. It's not from the mother's perspective, but forgetting to optimize the timely birth dose at 12 hours within delivery, and also the first dose vaccine and to complete it. I think that has to be really stressed, that that is the most important aspect, and this antiviral therapy during pregnancy is an additional thing that you want to implement.
You talked earlier about stopping the antiviral therapy at a particular time and also the possibility of flare. Could you talk more about that?
Yeah, so most people would actually consider stopping at delivery itself. That would be good enough. But there are some fears that of the flare happening very early on. So there are some studies to show that even if you extend it to 12 weeks after, it does not really matter. There's no difference whether stopping at delivery or 12 weeks on the risk of having hepatitis flare, because flare is something that will occur anyway, even if you don't take antiviral therapy.
You concluded the talk by talking about the triple elimination.
Yes.
Could you please elucidate on that?
So the triple elimination is a framework to really have a coordinated approach of eliminating not just the hepatitis B, but on top of what is already existing for HIV and syphilis. So the hepatitis B is the new additional thing that has to be considered, and it can be coordinated with what has been done for HIV to actually have integration of the services to prevent further hepatitis B transmission.
And you had some particular dates that you had mentioned.
Yeah, the dates was really looking at the approach that has been given, and I use Western Pacific region as an example, which China is part of. And because in the Western Pacific region, they have actually introduced hepatitis B vaccination targets very early on. And because of that, the success has been actually seen even early on, when the reduction of the HBsAg or hepatitis B prevalence has been reduced to less than 1% in children. And we could see that there's tremendous benefit in reducing those infected as well as death. 7 million deaths to be exact in the Western Pacific region alone by introducing hepatitis B vaccination. So what this means is that if we actually just continue on as it is, it's good, but it's not good enough to reach the target at 2030 of achieving 0.1% prevalence of hepatitis B amongst children. So what we want to do now is further prevent, and that's why the introduction of incremental approach of testing mothers for HBsAg, and do more like introducing hepatitis B immunoglobulin, and as well as antiviral therapy for the mothers.
Very good, Dr. Mohamed. Thank you so much.
No problem. No problem. My pleasure.